Imagine trying to do something good for your body, like make a high-protein smoothie for breakfast or after a workout, only to find your protein powder is full of junk. Heavy metals, artificial sweeteners, and chemicals you can't even pronounce. It is frustrating when you try to do the right thing, but instead you just end up adding to the toxic burden in your body. As someone who cares deeply about what goes into my body, as well as the patients that I work with, I believe that what we consume regularly needs to support our health, not silently sabotage it. That's why I use Puri. Their protein powder is made from clean, high-quality ingredients, and it's third-party tested for heavy metals and contaminants because they don't just say it's pure, they actually prove it. You can find collagen peptides, whey protein, and plant-based options on their website. Check them out at puri.com, that's PUORI.com, and use the code LIFEAFTERIMPACT for a 20% discount on your first order. In the hyperadrenergic POTS, what you typically see is that the heart rate goes up and blood pressure goes up too when you're doing the tilt testing. Welcome to Life After Impact, the Concussion Recovery Podcast. I'm Dr. Ayla Wolf, and I will be hosting today's episode where we help you navigate the often confusing, frustrating, and overwhelming journey of concussion and brain injury recovery. This podcast is your go-to resource for actionable information, whether you're dealing with a recent concussion, struggling with post-concussion syndrome, or just feeling stuck in your healing process. In each episode, we dive deep into the symptoms, testing, treatments, and neurological insights that can help you move forward with clarity and confidence. We bring you leading experts in the world of brain health, functional neurology, and rehabilitation to share their wisdom and strategies. So if you're feeling lost, hopeless, or like no one understands what you're going through, know that you are not alone. This podcast can be your guide and partner in recovery, helping you build a better life after impact. All right, welcome to Life After Impact, the Concussion Recovery Podcast. I'm Dr. Ayla Wolf, and I am here with the birthday girl, Sophia Bouwens. Hi, Sophia.
Hello, Dr. Wolf. It's so exciting to be here.
Are you having a great birthday weekend?
I've had a great birthday weekend. I'm officially in my late 30s. Something about that feels like very adult to me. But
well, you're still young at heart.
I am. I don't feel old. My mom always told me life begins when you're 40. And my mom told me that too, and I didn't believe her. But let me tell you, it does. So waiting for life to begin. But it's been a really good birthday, reconnecting with a lot of old friends and just, living life. I'm excited to be here with you doing this kind of stuff. And I think our topic today is just really a good one. So do you want to describe what we're going to be talking about today?
Yeah, I thought it would be a good idea to dive into some of the nuances of POTS, postural orthostatic tachycardia syndrome, because I would say that more frequently I'm having women come into my clinic who tell me that they are concerned that they have POTS. And in some cases, when we go through a lot of autonomic testing and we look at all the data, it sure looks like they do. And in other cases, I've had people come in and say, I think I have POTS, and I've run them through all my tests. And I say, there's absolutely zero sign of you having POTS, but that's not to say that we need to discount their symptoms. In one particular case, my concern was that she maybe actually had cervical instability that was driving a lot of her autonomic symptoms. And so after going through all of the testing, I felt pretty confident in saying, nothing that I see here looks like POTS. However, I want to refer you out for a DMX, a digital motion X-ray, to get some better data on what's going on with your neck, because I'm concerned that you might have some cervical instability going on.
Yes, and the upper cervical and the autonomic system are so intimately related. So that's huge. POTS can be such a tricky thing to diagnose or to even start to tease out. And I love that you have ways to assess whether or not it's likely to have be POTS or some other type of autonomic dysfunction.
Yeah, so I have a big chapter in my book on dysautonomia and autonomic dysfunction. And, I start out that chapter with a very long list of possible symptoms. And so I think for some people that might be eye opening because it is able to connect a lot of the dots for why they might be having a lot of what we might call non-specific symptoms that don't necessarily point to one easy, simple diagnosis.
Right. So I'm sorry to interrupt you.
No, go ahead.
I was just this is such an interesting component of this because I haven't had a patient recently. I think I may have mentioned this patient before, but their first original referral was for peripheral neuropathy post viral infection. So they got, or no, post Guillain-Barre. They got Guillain-Barre, and then they had this neuropathy that wouldn't go away after this acute episode of it. And so I started treating them for this neuropathy, and just we kept like teasing in different symptoms would kind of come out. Some things would get better, some things would get worse, or things would exacerbate. It just wasn't going the way that I thought it would go. So we were teasing in, and I really started honing in on like, actually, there's autonomic dysfunction here that's disrupting circulation to the extremities, causing neuropathy. And eventually, this heart rate component started coming up where they first were saying anxiety, and then their anxiety would get better. And it wasn't until like far too long that I realized, actually, I think you have POTS. I think that there's something like it was this aha moment. So I reached out to the referring provider and said, like, could you put a referral in for a POTS assessment? And I talked to some of the members on our vestibular team, and they were like, oh, well, we do have a tilt table here, but you need to go to a cardiologist to get assessed for POTS, like a specific neurologist, because they have to use like a 12-lead EKG to assess for this. And I was like kind of stumped by that because I just thought, no, yes, okay, maybe there's like this one valid test, but there's other ways we could assess this on the ground and make an impact before they get in to see a cardiologist or a neurologist for this test that like we could do here.
Yeah, I think what you're getting into is kind of this murky area of who in terms of scope of practice. And so
Mm.
I think that perhaps the vestibular therapist was saying, well, we might be able to work with somebody that has a diagnosis of POTS, but because of our scope of practice, we need to actually get somebody to a cardiologist so the cardiologist can give them the actual diagnosis, and then they are then sent to us with the diagnosis, and then we can work with them.
Oh,
And so
it's like
I
inefficiencies of medicine. Isn't it true?
Well, it is very inefficient if those cardiologists have a 2 to 6 month waiting list for sure.
Meanwhile,
Um,
this patient's suffering. So I wonder, you talk about some like different considerations for diagnosing, or you have these assessments. Can
yeah,
you share
so
with the audience what that is?
Yeah, I mean, for me in my practice, I'm all about observing, right? I'm all about observation, collecting data. And then if I collect enough data and I say, hey, I think you really do need to maybe go and have a full autonomic reflex testing panel done, I'll refer out for that. But with the knowledge that there's typically a 6 month waiting list, at least where we live, because there's only
Mm-hmm.
two major clinics that do that. But absolutely. I wouldn't wait to collect the data on what someone's autonomic nervous system is doing because that's super easy data to collect. I mean, having a heart rate monitor, a blood pressure cuff, a tilt table, these things are pretty basic. And they're usually found in a lot of clinics.
Yeah,
And
and maybe we wouldn't be the ones to diagnose POTS, like the classical POTS, but we could work with someone with these POTS-like symptoms and make improvements if we're understanding what's really going on.
Yeah. And so I think that it's important to recognize there's a difference between postural orthostatic tachycardia and postural orthostatic tachycardia syndrome, right? So
Mm.
as soon as you add syndrome to the end of that, you've got a legit diagnosis. But certainly there's nothing wrong with saying, hey, we are observing postural orthostatic tachycardia in this moment. let's keep monitoring it, and then let's make the appropriate referrals, right?
Oh, right. Yes. So what kind of assessments might you look at or do? You talk about this in your book. How might you start to assess for this? You shared a little
Yeah.
bit about this exploration for your, actually, you don't have like POTS, but you have maybe cervical instability. What are some of the things
Mhm.
you did to tease that out?
For starters, there is an age difference. So when we look at, say, like younger teenagers, age 12 to 19, the diagnostic criteria for POTS is actually seeing a heart rate increase of greater than 40 beats a minute on a tilt table test, whereas for adults, it's 30. And so
Hmm.
that's important too, is that if you're working with a younger individual, they actually might have, they have different criteria for diagnosing POTS. So,
Yeah.
so that's one thing I want to mention. The other thing is going back to this idea of as a syndrome, the symptoms. If you're looking at really strict criteria for POTS, so that there's even, I read all these research papers where they're saying that the criteria for POTS has kind of gotten like broader and broader and broader. And so then all of a sudden more and more people can be included in it. And there's POTS is rather a newer diagnosis. And I think the criteria is still, in a sense, evolving as we find that different things are causing it and there's different manifestations of it.
Hmm.
So the very first established definition was in 1982. So that's not that long ago.
No.
And so when we think about it as a syndrome, some of the strictest criteria states that it actually needs to be persistent or present for 6 months or more.
Wow.
And so that's one thing. The other thing is that this, going back to that same idea, is that this increase in heart rate for adults of greater than 30 beats per minute when you go from, laying down to standing or on a tilt table, um, that's reproducible. It's not just happening once.
Hmm.
And I've
Yep.
certainly had, cases where patients come in, you tilt them up, you see their heart rate immediately spike, and then the second you bring them back down, the heart rate goes right back down pretty quickly, and then you bring them back up and you see it spike again, and it is very reproducible. So that's one thing to kind of keep in mind. The other is that this elevated heart rate does occur within 3 to 10 minutes. So that's the other piece where I have seen people stand up and their heart rate doesn't do anything for, say, like the first 5 or 6 minutes. Then all of a sudden you hit a 7 minute mark and you see it skyrocket. And
Hmm.
so that 10-minute window is important.
That time window that you mentioned, like for example, that patient who didn't have the heart rate spike for 7 minutes, is interesting because I don't think if you're just living your daily life, you would connect that when I stand up, I get a rush in heart rate if it's happening 7 minutes after you stand up. You like go about your life and then all of a sudden you feel like, oh, my heart rate is like racing. You get this sense of anxiety. If it's 7 or 10 minutes or 8 minutes after you stood up, I don't know that I would connect that. Do you see patients that have this like aha moment?
What I've noticed is that some people are very aware of their heart rate and their tachycardia, and other people are not. So there's definitely a variability in terms of someone's own perception of what their heart rate is doing. Some of my patients,
Mm,
when I'm watching their heart rate, they don't necessarily feel like it's racing, even when it is. And then other people are almost hyper aware. So I'd say there's definitely a broad range of what the patient is actually experiencing in those moments.
mm. Yeah, I can see that. And that might be another reason why it's hard to pin down this diagnosis, which can be so crucial.
I think it comes back to the idea of interoception and this idea that we have this part of the brain called the insular cortex, which is where we have our interoception, our ability to be aware of what's happening internally. And when I was writing my book, I did come across a very interesting research paper that I referenced that talked about this idea that some people with dysautonomia, they can actually see some dysfunction within these regions of the brain that are involved in interoception. And that can lead to a lot of poor feedback between the brain and the body, where maybe people don't recognize when they're hungry, or maybe people don't recognize when they're cold, or maybe people aren't getting proper signals from their body to say that something is off. And so it's like this dysfunctional feedback loop between the brain and the
Yes.
body.
I see that all the time, and you feel disconnected from your body is one of the ways people will say it to me. Like, I just don't feel like I'm like fully in there, or I want to be more connected to my body.
Yeah.
It's feeling like you're not fully like inhabiting, or you don't know when you're hungry or you're tired or you're thirsty. You can't tell if you're cold. Yeah, it's interesting that you say that. Do you see that connect and correlate with an autonomic dysfunction?
Again, I think it can go both ways. In some cases, people aren't really paying attention to the cues their body is giving them, and that can be problematic. And then you can have the exact opposite, where people are too in tuned, and every
Yep.
single little sensation is a cause for anxiety. And there's a bit of almost a hyper focus on every single little ache and pain and twitch and twinge. And so
Absolutely.
yeah, it can go both ways, really.
I see both of them. But these testing opportunities, that's why I think they're so helpful, because patients, we all know, they're not super reliable in their own just reporting, because it can change so much, or what they're even aware of capturing
Yeah, and
or saying to you.
exactly. And I think another good example of that is when people have what I call increased heartbeat awareness, where they feel like their heart is pounding. And what I've come to really recognize is that people's heart can be pounding, but it doesn't necessarily mean that it's pounding fast. Although many times when people feel like their heart is pounding, they think that it actually is an elevated heart rate. And sometimes it is, but sometimes it isn't. And so, again, we have to really get the data to say, what is your heart rate doing in different positions? What is your heart rate doing when you're laying down? What is your heart rate doing when you're standing? What is it doing when you're sitting? And what is it doing when you're exercising? And what is it doing when you stop exercising? Like, all of that data is super important to understand. Yes, you may be feeling a pounding heart, but is it actually an increased heart rate as well?
So, if you don't have a cardiologist to refer to or to work with in a timely manner, what are some of the ways, like, how do you start assessing for POTS in your office?
I've been drinking Purity coffee now for over 2 years. And one of the things that I absolutely love about Purity coffee is the fact that they do rigorous testing for mold toxins, pesticides, and heavy metals, which allows me to be able to drink their coffee and rest easy knowing that I am not consuming toxic chemicals, mycotoxins, or possibly heavy metals. I know a lot of our listeners are paying a lot of attention to their health and trying to do everything they can to stay healthy. And if you are a coffee drinker, one of the things that I would recommend is making sure that you're drinking a coffee that isn't putting more toxins into your body. If you would like to try Purity Coffee, you can get 20% off your first order using our promo code LIFEAFTER20 by going to puritycoffee.com and entering that in the promo code box at checkout.
Really basic, by having people first, I just have them sit down, right? And look at what is your blood pressure, your heart rate, your SpO2 numbers when you're sitting. And some people, they have white coat syndrome, right? And they have high blood
Mhm.
pressure when they're sitting. And so if that's the case, it's also important for people to monitor their heart rate at home and to sit for 5 minutes without talking to anybody, and then take their blood pressure, like, multiple times, just to see, is my blood pressure consistently way lower at home versus if I'm in the doctor's office? So sometimes you
Sure.
got to,
That's a good.
yeah, sometimes you have to troubleshoot the white coat syndrome.
Yeah.
But then I have people lay down and, again, not talk. Lots of people like to talk, and oftentimes they're telling you about all the stressful things going on in their life, and that's
Mhm.
gonna affect the data. So the key is to not talk. And so having people laying down, again, looking at blood pressure, heart rate, oxygen, and symptoms. And then when you tilt them up and have them at a tilt for 10 minutes, you're monitoring everything. Again, blood pressure, heart rate, symptoms, and you're documenting all of that. And so through that, you can start to gather data on what their heart rate is doing in relationship to whether they're laying down versus whether they are upright, and then what happens when they've been upright for a whole 10 minutes. The other thing about POTS is that part of the POTS diagnosis is that it isn't occurring in the presence of low blood pressure. So if you see that somebody has orthostatic hypotension, where their blood pressure is dropping, that part of the POTS diagnosis is that you're actually seeing the tachycardia in the presence of normal to high blood pressure.
Okay. So that's an interesting tease. In your book, you talk about additional diagnostic considerations, maybe like this high blood pressure, low blood pressure.
Yeah.
When you're assessing for POTS, could you talk about those?
Yeah, so to go through kind of a few of these other nuances of the diagnosis, typically, like what you should see is that the symptoms that people get when they are upright, whether it is dizziness, nausea, lightheadedness, increased pain, those symptoms typically get better pretty quickly when you bring them back down. So that's kind of one piece. The other piece is that if somebody is fainting, that alone is not enough to say that you have a POTS diagnosis, right? You got to collect the actual data on the heart rate. So that's one thing. And then you also need to exclude other causes. Like I've had a patient who was prescribed a certain medication, and as soon as she went on the medication, she developed basically postural orthostatic tachycardia. And so you have to kind of understand too that you don't want to give someone a POTS diagnosis if you haven't ruled out other causes, like whether it's a medication or something else.
Sure.
So secondary causes of orthostatic tachycardia need to be excluded. So those are some of the kind of nuanced considerations. But then if somebody does have a pretty clear postural orthostatic tachycardia presentation that's been there for months, and it's repeatable, then we have to also understand that there's different categories of POTS. And that
Yes, I was going to get into this next.
Yeah.
Please talk about this.
So people can have multiple categories all at the same time. So I'm going to talk about the categories as separate things, but some people have, they can have more than one. Yeah, they can fall into more than one criteria. But
welcome to neurology, not to make it more confusing. There's never a clear cut, but there are some considerations.
Oh my gosh, biology is messy. There's no less black and white.
No, we wish there was, but it's nice to understand some parameters so we can see a spectrum. Let's talk about them. You break it down into multiple subtypes.
So we have the hyperadrenergic POTS, which is actually the most common subtype of POTS. However, I was listening to a different podcast and there was a medical doctor actually talking about, he was expressing frustration that people kind of ignore this hyperadrenergic component. So I thought that was kind of interesting that even with this being the most common subtype, that it's still maybe, not quite acknowledged to the degree that it should be. But in this subtype, there's actually too much norepinephrine in the system. And that could be because there's just excessive production of it, or there's an excessive amount of release of this neurotransmitter, or there's a failure of proper reuptake so that there's just more of it in the system.
Can you talk about what norepinephrine is for people who might not understand that neurotransmitter quite as well as someone with a...
It's a neurotransmitter produced in the lower brainstem, and it's highly involved in being alert. And so, when we talk about people that maybe feel super kind of dopey or drugged up or tired, some people don't produce enough norepinephrine and they can just feel very kind of sleepy and out of it. But when there's too much of it, it's almost like you could say people maybe feel a little bit more anxious and kind of hyper alert.
Kind of wired, right? Like I can't rest or I can't fall asleep. Do people with a level of norepinephrine have difficulty sleeping?
Potentially. And in this population, I would say that with dysautonomia in general, people's sleep cycles are often disrupted as part of it. because the autonomic
Yeah.
nervous system controls our circadian rhythms and a lot of our sleep
Mhm.
rhythms. Yeah.
All this digestive and sleep and reproductive. So if you have this hyperadrenergic type, which is the most common, you have too much norepinephrine in your system. Is that what you're saying?
Yeah, and that can actually be measured in plasma levels of norepinephrine. So this is something that can be tested to say, is there too much? And we can actually measure that.
Mm.
So that's part of it. But then the other part is that leads to orthostatic hypertension. And so in the hyperadrenergic POTS, what you typically see is that the heart rate goes up and blood pressure goes up too when you're doing the tilt testing.
Mm.
And so that's important to recognize because there are some drugs like the antidepressants, the Cymbalta Effexor, which are norepinephrine serotonin reuptake inhibitors, that you wouldn't want to
Mm.
place somebody on because if they already have too much norepinephrine, you certainly don't want to give them a drug that actually supports the production of it and the
Yeah.
promotion of it.
Yes, that's huge. But that's maybe another reason why this physician was expressing that there's not enough people who really pay attention to this subtype, even though it's the most common. There's so many considerations a care team would have to have, like you just mentioned, with medications to treat other components that might drive this.
A lot of people that suffer from migraines as part of their picture of having hyperadrenergic POTS, those two things seem to be linked. And so when
Mm.
you do have people with dysautonomia, they often have either headaches or increased frequency of migraines as part of the clinical picture, and so that seems to be more common with the hyperadrenergic POTS. And
Mm.
that might also indicate that there's a hormonal imbalance as part of this clinical picture because many people with migraines seem to have imbalances between too much estrogen or not enough progesterone or these kind of estrogen progesterone imbalances. And that's where it also would indicate that it might be good to really look at someone's hormones and do some hormone testing to see what their estrogen levels are at different times throughout the cycle to understand if that is, part of this picture too. I think it's like 70% of POTS cases is in females between the age of say like 15 and 45. It's like, well, what else is happening in women between
Mhm.
age 15 and 45? Well, their hormones are supposed to be cycling in a very orchestrated manner. And so maybe we
Uh-huh.
need to do a whole lot more research on the hormonal component and how much that might be actually contributing to some of these POTS type presentations.
It's not so simple. Again, we're getting into the messiness of biology.
I know.
So we have the hyperadrenergic POTS, but are there other types?
The next one is the hypovolemic POTS, and this exists when we have this dysfunction within the renin, angiotensin, aldosterone system, which regulates fluid balance and water metabolism in the body. So, what this creates is a low plasma volume, and you can actually measure that by doing a 24-hour urine test. And so, people basically have to pee into a big container and collect their urine for 24 hours. And then you can actually look at the levels of sodium and potassium and creatinine. And you can see that there is some dysfunction within these levels. And basically, a lot of these hypovolemic POTS patients, they feel very lightheaded, very dizzy, very weak when they're standing because of this, decreased plasma volume. With this one, this is where a lot of people do find some relief in doing the things that help to retain water, like salt. A lot of people will find that by increasing their salt intake or doing salt tablets or doing electrolytes to try to help support the fluid retention and kind of boost that plasma volume, that can be
Yeah.
helpful, as well as compression garments. And so this is the type of POTS where like those types of therapies can be helpful management strategies.
Yeah.
And
Is there another one?
yes,
Another type?
so then we have POTS plus mast cell activation. And so mast cell
Yes.
activation syndrome is essentially a situation where people have increased mast cell activity. Mast cells release histamine. Histamine causes vasodilation. And so this is where many people will break out into hives or they'll have the like
Mm.
splotchy red skin. A lot of times they have these symptoms come on after they eat meals. And so there's certain kind of triggers for this as well.
Is that more the immune system component? I mean, you think of mast cell activation. They're usually
Yeah,
in response to some immune function.
right. Essentially, their mast cells are overactive. And so they have just this increased response that is causing a lot of these symptoms. A lot of these people will have shortness of breath, they'll have increased headaches as well, excessive urination, and a lot of them have a lot of nausea and even vomiting.
Mm.
And so, again, this can be measured. You can actually measure methylhistamine levels in the urine. The other reason why catching the mast cell activation component of it is that most people with POTS are actually given beta blockers to try to lower their heart rate. That's like the most commonly prescribed medication when somebody has postural orthostatic tachycardia. But when they have mast
Mhm.
cell activation, beta blockers are actually kind of cautioned against. So this is another reason why understanding the different kind of subtypes of POTS is so important is because they can actually impact treatment guidelines.
Absolutely. And would you approach them with treatment differently?
From more of a holistic perspective, I pay a lot of attention to liver function when people have mast cell activation syndrome. There's oftentimes a liver component that needs to be supported. And there's, herbal formulas that work really, really well to help prevent the production of histamine and clear out excess histamine. So I think in this particular case, there's often a lot of, gut issues and kind of gut liver dysfunction that needs to be addressed.
And in someone with a hypovolemic POTS, would you take a different approach?
That is where you also need to, well, so I guess with all of the POTS presentations, you also want to pay attention to the concept of where am I in space? You have to ask that question of, okay, why am I having symptoms when I go from laying down to standing? And there's different systems in there's different systems. We have redundancies within our nervous system, but one of the systems is this baroreceptor system. So, we have these receptors in the carotid arch and in the neck, in the arteries in the neck. And so they're supposed to pick up the fact that when you go to stand up, we need to have a slight increase in heart rate and we need to have a slight increase in blood pressure so that instead of gravity taking our blood and bringing it down towards the ground, that our
Yeah.
system is overcoming that by having blood flow, enough of it get to the brain so that we don't pass out, right? And
Hmm.
so part of that is this idea of these baroreceptors saying, okay, we've just changed position. And so now we need to respond by increasing blood pressure a little bit. And so the baroreceptors are, picking up on changes within the system, changes within the pressure, and then signaling to the brainstem. And then the brainstem is responding and then signaling to the heart. And so this is this very finely tuned orchestra that if it's not happening appropriately and people lose what we call baroreceptor sensitivity, that can be part of the problem.
Can we just take a second to just to appreciate how incredible our bodies are, that they can adjust to gravity how our blood is flowing so that we feel normal. And we are so quick, we don't even know what's happening because our systems, when they're healthy, just do this so naturally. And then these little disruptions, whether it's in the liver or in the brainstem, or if it's in our adrenals, they can really affect the sensitivities of the receptors or the abilities for these loops of information to respond appropriately to the changes in our position and gravity. I mean, I think that's pretty cool.
I know. I mean, when
So,
things are working well, we don't appreciate it, right? We don't really appreciate what our
right.
system is supposed to do until it stops doing it.
And then it doesn't do it right. And we're like, whoa, oh my goodness, this is nuts. It's so disorienting. And then we have to have the ability as providers to tease out which part of this really intricate system is the disruption happening in, this miscalibration of the system that might be driving all of these other symptoms. can be coming from cervical proprioception. It can be coming from adrenal function. It can be coming from liver function. It can be coming from a head injury or autonomic function. It can be like so many different things, hormonal changes. Like there's so many different things that we have to be able to see, which is why I think it's really helpful to have a specialist who understands these things very cohesively and is teasing out maybe these subtypes or what the symptoms are that are really presenting.
Yeah. And the other thing, well, I guess a couple of things that jump into my mind. One, I just want to go back real quick in the topic of the baroreceptors, in that you can actually test the baroreceptor sensitivity by doing a Valsalva maneuver. And so by bearing down, you're changing your interthoracic pressure, which, increases blood pressure. And so by doing a Valsalva maneuver and looking at blood pressure and heart rate responses, a clinician can actually see what the body is doing in response to this increased pressure. And then when you let it off, what is the reaction to that? And so by looking at these changes in blood pressure and heart rate, when somebody is doing a Valsalva maneuver and then releases that, gives us, some data to say, are the baroreceptors interpreting that information correctly? So I just wanted to throw out that there are different ways to actually test for baroreceptor sensitivity, which is great. Even if we don't have a 12 lead EKG, or even if we don't have continuous blood pressure cuffs monitoring, we can still collect data on a tilt table test and on a baroreceptor, sensitivity test, and on a 5-minute sustained hand grip test and pupillary light reflexes. So at the bedside, functionally, we can still assess the autonomic nervous system to, like I said earlier, observe what's happening with the patient's autonomic system, and then start to look at where is this dysfunction, where are other areas of dysfunction that might be contributing to these errors in the system, and how do we restore more integrity to the system. And so part of that is doing additional troubleshooting. For example, I have seen a lot of patients that have mold exposure have a lot of tachycardia, and they have a lot of the kind of pounding heart sensations as part of like a mold exposure type symptomatology. So sometimes you've got to go really deep and say, are there, environmental issues here? Is there like Lyme disease as part of this diagnosis? Is there a virus? Is there an autoimmune component? So there's a lot of troubleshooting that has to happen, and then also paying attention to like the hormones, like we talked about. So there's just a lot of diagnostics that have to go into it to really try to figure out, the big picture of everything, and not just looking at POTS as, oh, this is a situation of a rapid heart rate. Like there's so much more to it than just that one component. So that's kind of big picture. And I think that that's where a lot of people get lost in the system, is when they just go down the route of being given medications to artificially control the autonomic nervous system. So like one of my patients that was diagnosed with POTS, if she was laying on the floor, her heart rate would go down to 50. When she stood up, her heart rate would jump up to 150. So
Wow.
so she was so symptomatic. I remember when we did our initial 15-minute kind of consultation over telemedicine, just because she, so she could find out more about the work that I do. Her video popped up on the telemedicine, and she was literally just like spread eagle on the floor. Like she's like, I can't even sit up for this conversation. Yeah. And
Wow.
so, if you can imagine your heart rate going, changing by 100 beats a minute when you go from laying down to standing, that's crazy.
That's
I mean,
nuts.
yeah. And so, she was given one medication to try to lower her heart rate, but she was given another medication to increase her blood pressure. But if you're taking a medication that lowers your heart rate, but your heart rate is 50 when you're laying down, well, it's like no wonder she felt worse on that medication, because our autonomic nervous system is meant to respond in the moment. And when we artificially try to control it with pharmaceuticals, it doesn't account for a situation where, yes, her heart rate might be 150 when she's standing, but if she's on a heart rate lowering medication and then she goes to lay down and then her heart rate's now 50, it's just, you're taking away her body's own ability to try to figure that out.
For sure. And that's an important part of rehabilitation and recovery is like, how do we actually help the system respond better and like re-get its own
Yeah.
integrity? There's so many nuances in care and difficulties and challenges for patients who might get misdiagnosed or miscategorized, or the providers might not fully understand what's going on, so put them on the wrong medication. I wonder what kind of hope we can give patients who are struggling with these things to like feel like, okay, if I do want to find someone for help and like assessing this, like what do I look for and what kind of provider do I need?
I think having a provider who's willing to collect a lot of data and do a lot of these functional tests, and then to also look at the big picture of, is there a viral infection? Is there an autoimmune disease that hasn't been discovered yet? Is there a mold exposure? Is there a concussion? Is there long COVID? Is there mitochondrial dysfunction? Is there a baroreceptor sensitivity issue? Is there a vestibular disorder that's driving this? They got to find a practitioner who understands all these different potential factors and is willing to look at all of that and start to rule certain things out or rule certain things in, and then continue to go down these rabbit holes of, doing the investigative lab work and the diagnostics and the testing. And then also at the end of the day, we keep coming back to the studies that show that exercise is one of the best ways of helping the autonomic nervous system.
Yes.
And you have to figure out how to do that in a way that is obviously safe for the patient, especially if they're dizzy and nauseous, and, understanding that it's not, okay, let's just immediately try to get you on a treadmill and walking 15 minutes a day. It's like, no, like some people that's not possible, right?
Working with specialized providers who understand how to taper your exercise dose and your exercise engagement to help your system is huge. That's really important.
Yeah. And I think that's where like a recumbent bike can be really helpful, because people can actually be sitting down and still getting some blood pumping and doing exercise, but they're seated. Whereas I think in a lot of cases, treadmills are not necessarily the immediate starting point.
The best.
Depending on,
For
again,
sure.
just how symptomatic they are. But
I think we understand that everyone has to have like their own prescription based on your symptoms and other things. And your book does a really nice job of helping people understand that. And now our audience has some resources and maybe some better understanding of like why and in what ways these complexities can make a really big difference in how you approach treatment and the outcomes you would see.
yeah, I mean, a lot of people will ask me, they're like, do you think I should go and get tested, or do you think I should go see a cardiologist? And my answer is always yes. Like, go get as much testing and as much diagnostic workup as you possibly can. And then you get to get the information, the right diagnosis, and then figure out how to move forward from there. So it's, I'm never against going to see specialists and going to do more testing. I'm always highly recommending that people do those things. And then, like I said, they get to get the information, get the right diagnosis, and then figure out strategies for how do I want to approach this from here.
Yeah, and that's the thing is like sometimes, and I'm all for the testing, but it's a frustration. Like, okay, once you get the test, oftentimes they just say, okay, like this is what you
Right.
have.
And that's because a lot of doctors will actually tell their patients there's no cure for this. And I think that what they mean by that is there's no single pharmaceutical drug you can give somebody with dysautonomia to then just fix their autonomic nervous system.
Yep. I think your work, Ayla, has been amazing in this. I'm super excited to share this with the public and get this information on this really complex condition out there to start to hopefully make a good impact.
Well, thank you so much. I mean, this is a really difficult and complex topic. And even for the people who understand it really well, it doesn't always mean that recovery is necessarily quick, fast, or easy. And so I think it's also one of those things where, helping people to understand expectations, and that a lot of times it's baby steps, and, really just trying to make sure that we're heading in the right direction. So it requires a lot of patience on the part of both the patient and the provider, to really work through this and to come up with treatment plans that are helpful. And so again, it's not a simple topic and it's not a simple treatment plan. And I think that, part of the difficulty in writing this chapter in my book is that I couldn't just give people, here is the treatment, because the truth is everybody needs something different. But I hope that at least this gives people some things to think about and maybe some avenues to explore. So thanks for diving into this with me.
Yes.
For our listeners, if there's any topics you'd like us to cover, please send us an email at lifeafterimpact@gmail.com, or you can click the Send Us a Text link in the show notes. My new book, The Concussion Breakthrough: Discover the Missing Pieces to Recovery, is also now available on Amazon, and you can link to that through the show notes or through our website at lifeafterimpact@gmail.com. Thanks for listening. We'll see you next time. Medical disclaimer. This video or podcast is for general informational purposes only and does not constitute the practice of medicine or other professional healthcare services, including the giving of medical advice. No doctor-patient relationship is formed. The use of this information and materials included is at the user's own risk. The content of this video or podcast is not intended to be a substitute for medical advice, diagnosis, or treatment, and consumers of this information should seek the advice of a medical professional for any and all health-related issues. A link to our full medical disclaimer is available in the notes.